She's been very kind to agree to come to all of us. And, and he is such a huge persona by himself in the in imaging in this country. A special thanks to him, indeed.
These are very two interesting topics. And when you talk of artificial intelligence, I was just reading the newspaper. It was very, briefly put in about the artificial intelligence in a common man's word, that how it can help the courts. That if you have all the data that is over there, and for example, there is a case, the both opponent as well as the litigant, both are evidences are there, they upload it, both are there, and then this is presented to the judge artificially, and it is matched with the judgments regarding these evidences that can be matched. And then with the artificial intelligence, they can also match with the previous judgments, so that the judge gets help as to what has happened previously regarding these judgments. And then when these judgments are accurately matched, they give the judge the probabilities of which way this case should be going. So the backlog of lakhs and lakhs of cases
I can imagine.
will create in no time. So that was very easily understandable, but I am sure that Harsh is going to give us some very good, interesting similes in that, because he is talking of foes probably as well. Maybe he has found the foes. So he has a very interesting topic of when we are talking of friend or foe, as far as artificial intelligence is concerned. We move on to a diagrammatically opposite area where we are talking of friends and foes.
Yeah.
It is a great pleasure to introduce my great friend.
Welcome, Harsh. Welcome.
Thank you very much. Thank you very much. I'm among so many friends. I see so many names I know. Thank you.
It is a pleasure to introduce you, sir. A founder and chief radiologist, Mahajan Imaging, New Delhi. He is an Indian radiologist, as he himself says, and one of the pioneers of imaging technology in India, to which I am also to some extent privy. He is the founder of Mahajan Imaging, as I already said. He is a former president of Indian Radiological and Imaging Association and the director of the Department of Nuclear Medicine and Bone Densitometry at the Sir Gangaram Hospital, New Delhi. He has served as the honorary radiologist to the President of India and as the honorary consultant to the International Atomic Energy Agency. He is on the board of advisors of Rashi Hood University. He has published several articles on clinical radiography and other medical topics. The Government of India awarded him the 4th highest civilian honor of Padma Shri in year 2002. So Dr. Mahajan, it is a pleasure to listen to you, and you are going to at least introduce us to this beautiful topic of artificial intelligence in imaging, friend or foe. The most intelligent person in radiology can tell us what are the foes behind them. Over to Dr. Mahajan, please.
Thank you very much, Dr. Wattal, and thank you, Seema, Alok, and the other organizers who've invited me. It's indeed a pleasure to be here at this forum. I'll share with you our own journey of the last about 2.5 years that we've been involved in our research division with artificial intelligence, and really try to chart a path for where we are going, where this whole technology will take us, and whether it's a friend and foe or foe, I leave it to all of you to decide after I've done with my talk. Now, what really is artificial intelligence? Artificial intelligence, it may surprise some of you to know, is a term which is not new. It was coined in 1956, and it refers basically to the ability of computers to learn without being explicitly programmed. So that is what AI really means. It, of course, has gained recent popularity, and that is more because of the exponential increase in computing power. Each of us carries a supercomputer of the 1990s in our pockets today. And then in 2016, a new approach of deep learning has had widespread implications and applications. So basically, AI is using high-end computing to find hidden patterns in data, and it has a significant overlap with the field of computational neuroscience. It has also been said that AI is whatever machines can't do yet, since what constitutes AI and what does not is constantly changing. So really the definition itself is undergoing a constant change. Now there are types of artificial intelligence, artificial narrow intelligence, and we remember this picture where Deep Blue, the IBM chess computer, actually beat Garry Kasparov on chess, the world chess champion at that time. And this is artificial narrow intelligences that you're able to teach a computer one function, one task, and it's able to do it beautifully. And this is what happened with Deep Blue. Then there is artificial general intelligence. This is an emerging field. This is the next frontier. And this is where humans are as such. This is reinforcement learning. There is self-learning. You teach the computer chess, it's able to learn something more. From AlphaGo to AlphaZero, chess to shogi. So this is something which is really where healthcare and AI are. And then there is the field of artificial superintelligence, and the world is divided about this possibility. It describes the point in time when AI becomes stronger than humans. You know, we have those science fiction books where, robots will rule the world. And, a lot of people are skeptical about it. But having seen in the last 60 years of my journey, anything that was written up in a science fiction book has come true. But I hope this part of it does not really come true. Then there are two broad categories of AI applications. One, something that humans can do, but AI does better or faster. Humans can monitor CCTVs, but one person may be able to monitor 8, 10, 15 maybe, whereas AI, computers, can monitor thousands and thousands of them. Similarly, humans can translate language, but we have Google Translate, which can translate so many more of them. And then there is an application which humans just cannot do. And this is, something we use every day. This is our Google Maps. There's no way a human being will be able to predict that how much time it's going to take from going from one part of the city to another. Now, AI has percolated into all aspects of healthcare: preventive and population health, prediction of cardiovascular risk factors from retinal fundus photographs via deep learning, a paper published in Nature in 2018, next-gen psychiatric assessment using smartphone sensors to monitor behavior and health, diagnostics, radiology. There are extensive applications and we'll look at them. Pathology, this is slowly picking up due to lack of digital infrastructure. But as we get to digital pathology, this is also going to kick in a big way, just as radiology has. In the field of genomics, and we have a genomics lab, and machine learning techniques form a part and parcel of next-gen sequencing. I, for one, as a radiologist, was not really aware of this. And then in the field of therapeutics, machine learning and other technologies are expected to make the hunt for new pharmaceuticals quicker, cheaper, and more effective. Again, Nature, May 2018. And then we have the IBM Watson for drug discovery, most important for biologics. Now, learning or training is the fundamental basis of all AI today. This is the traditional technique, and most healthcare AI is focused on this. It is labor intensive, and ground truths is vital. If I'm looking at a chest X-ray and feeding, say, 100,000 chest X-rays with different labels into a computer, then if my report, which I'm feeding in along with the X-ray, if that is correct, that is how good my AI algorithm will become. They say garbage in, garbage out. So your ground truth is vital. For high accuracy, better the labels, better the output. For example, Facebook's face detection only works once enough pictures of people are tagged by users, and chest X-ray algorithms I alluded to require thousands and hundreds of thousands of labeled images. And now if you look at this figure, you know, different people may write a 3 in different words, in different ways. And so we have to feed all of those into the computer so that the computer is able to differentiate 3 from 1 or 2 or something else. And how is an AI algorithm developed? First thing is to collect data, to find the data, which is the most important step. Find as much heterogeneous data as possible. That addresses the problem that you're trying to solve. So you want data from, say, if we're talking of chest X-rays, you want some from AIMS, some from Mahajan imaging, some from Gangaram, some other from a Fortis, Max, and some even from the PHCs. As diverse a data, as heterogeneous a data that you have, better is your quality of data, and better you'll be able to train the model. So the data is split into 2, the training and the validation data sets, and the algorithm finds patterns itself. So once you've labeled the data and fed it into the computer, it will be able to find patterns itself. Then is the next most important point, and this is where AI in healthcare is stuck at the present point of time. There are hundreds of companies, hundreds of startups, hundreds of universities which are building AI data, but how much of it is in use? Hardly any. That is because techniques for validation are still to be developed, are being developed. I'll show you some work which we've done in this field. Unless the trained model is validated on balanced data and on external data, you will not be able to use it very well. And hence you test the model before you're able to put it into day-to-day clinical practice. And this validation and testing is where most of the problem currently lies. And once this problem is overcome, you will see a dramatic increase in use of AI data. Now, if we talk of the radiology value chain, and much of it would be similar to pathology, to microbiology. One, patient scheduling and preparation. The next step, the scanning and image acquisition. Third step is processing of what you accessed and analysis of it. And the fourth is the holy grail, the diagnosis. This is the time when the computer will write the report and the radiologist will become redundant. Now, if we talk of patient scheduling, now this is a paper which came out in 2018. Do remember that all of what has happened is very, very new. And this is from Mass General, machine learning for predicting patient wait times and appointment delays. So many times we have patients waiting and cursing that, doc, you called me at 10 o'clock, it's now 11 o'clock and my turn has still not come. And this is very, very common in MRI. And then you have those who don't turn up. And so there is a machine learning algorithm that's currently available, which very accurately predicts which patient will need to wait, how much will your appointment get delayed. And this is just based on the data of the first few months that have been fed in. And then predicting scheduled hospital attendance with artificial intelligence. Who are the patients who will show up and who are the patients who will not show up after you've given them an appointment. And you know the frustration all of us have when you are booking a patient for Wednesday and you are sitting free on Monday because the booked patient didn't show up. This also is a very robust data. And out of the 30 patients that you booked for, say, an MRI or a CT, it'll very accurately tell you these 3 won't turn up. Then is scanning and image acquisition. And this is some of our own work, which we presented at the ISMRM, International Society of Magnetic Resonances in Medicine in 2019, and the European Society, European Congress of Radiology. And this is towards virtual MR imaging. This is predicting T1 and diffusion weighted images from T2 weighted images. As you know, on MR, we need to do multiple sequences, get different kinds of images. Here, what our group has been able to do, and this is some path-breaking work, is get diffusion and T1 weighted imaging just from T2 weighted images. So you do not actually do the rest. And this is an example. On your left is a T2 weighted image, which shows a chronic infarct here in the left frontal lobe. This is a true diffusion image, and chronic infarcts are not supposed to appear bright on true diffusion. And that is what we see here. And this is a virtual diffusion image, which has been generated by a computer with an algorithm without showing it the true diffusion. And this also, and this was a huge surprise to us and is a huge surprise to the AI fraternity, this also didn't show up as bright. Whereas this is another image in the same patient where it appears nearly normal on the T2. On a true diffusion, you see there's an acute small cortical infarct, and this is also able to show it on the synthetic image. And even a radiologist cannot predict, looking at this, that there would be something, and the AI algorithm is able to predict that and be able to differentiate a chronic from an acute infarct, which without diffusion weighted images is very difficult for a radiologist to do. And these are some more examples. That's a T2 weighted image. You see multiple hyperintensities, these bright areas, and out of them, only this one becomes bright. And you know, all these are chronic infarcts. This is the acute infarct. This is on diffusion. This is on virtual diffusion. Another tiny little infarct in the head of left caudate nucleus on actual diffusion. And this is on virtual diffusion. This actually was something which startled many people around the world. And then something even more startling. Can you give me a CT scan of the chest and I give you a PET CT without actually doing the PET? This is something our group set on to do. And when they told me they want to do this, I said, you guys are crazy. How can it be? So just look at it. This we call synthetic PET. This was presented at the Radiology Society of North America in 2018, and we filed a patent for it. It's still awaited. And this is what it is. This is a CT scan image. This is a PET image. And in the PET, you see these lymph nodes which have taken up the isotope. And based on this CT scan fed into the computer, the algorithm actually predicted this synthetic PET. And does it not look exactly similar to the actual thing? This again is something which is unbelievable. We are doing a deep dive into it. We've shown the proof of concept and doing a deep dive, and hopefully this will be something which will be used around the world. This is an input CT image. That's an actual PET CT, and this is a synthetic overlay. Again, CT, actual PET CT, and this is a PET CT without actually doing the PET. This can have immense potential, especially in those parts of the world where PET CT is not available. Then automation of the MR protocoling process. Every time a patient comes, say, for a head CT scan, those cut lines which are put for the slices are put differently. Now there is a tool available already in use where the AI algorithm is able to recognize the various landmarks in the brain, and every time it will replicate the same. So when you're doing multiple exams and comparing them, there will be no problem in identifying them. This is something, again, similar to what we did. This is a group out of the US where they've been able to construct 7 Tesla-like images from 3 Tesla. So this is a synthetic image which has been created. Here you see a reconstructed 7 Tesla-like image. This is the ground truth 7 Tesla image, and they look very, very similar. And this is actually the 3 Tesla image. So again, a proof of concept. This is again to show you do a very quick scan, and then using AI, you're able to get a high resolution image. And this has been used in a CT scan, which is already available for sale. This was, it got FDA clearance in 2019. So instead of using the full dose of radiation, you use only 20%, get a very grainy image, and using AI, you're able to improve the quality. This is another a thing that we are doing along with the Institute of Liver and Biliary Sciences, where, you know, portal vein pressures, it's impossible to estimate them non-invasively. It is an invasive procedure. You go through the jugular vein all the way into the liver, do a wedge, and that's how you learn it. We are trying to use a triple phase CT scan, a 3-phase CT scan, along with the ground truth, trying to see whether on a CT scan we can predict what the hepatic venous pressure gradient would be. Moving on to processing and analysis, and this is an automated lumbar spinal canal detection tool. Again, a paper we presented in the ECR in 2019, where automatically using AI, you're able to get the area, the dimensions, the volumes of the lumbar canal, and also the height of the discs, whether a disc is compressed or not, all those you can do automatically. And this is automated liver, vessel, and tumor segmentation using an AI tool developed. This again is a poster we presented along with our collaborators out of Bangalore. So it'll give you the tumor volume, it'll show you the blood vessels, it'll mark it out, it'll do volumetry of the liver, all automatically. Definitely, radiologists will be out of a job, and this will be something which the liver surgeon can do himself. Then automated segmentation of white matter lesions. This is a company, a group out of Spain. Actually, my younger son works with them. And this is a case of MS, where they are able to not only count the number of lesions, but also the volume. And those of us who report MRIs of the brain, it can take an hour to report a case like this, because we have to count the number of lesions. And then when we are comparing, see what is the change. Diagnosis, the holy grail. And this is an AI algorithm. We helped GE Healthcare develop the first on-device, on the X-ray machine tool, which could actually detect the critical abnormality of pneumothorax. This was presented in 2018. And in 2019, this became a product, and all the brainstorming, annotation, validation, all was done at Caring. Caring is our research center, the Center for Advanced Research in Imaging, Neurosciences, and Genomics. Then this is a paper we are very proud of. This is the first paper ever to be published on AI in the Lancet, Deep Learning Algorithms for Detection of Critical Findings in Head CT Scans, along with our collaborators, Cure AI, and a training data set of 3 lakh CT scans, a validation on 490 CT scans. And just look at the AUC, intracranial bleed 0.94, fractures 0.96, midline shift 0.97, mass effect 0.92, and also automated report generation, which will tell you this is extradural hemorrhage, it's 20 ml, there's a fracture, midline shift, mass effect, all of those things automatically done by the computer, no radiologist, nothing. Extradural, subdural, how much is it? How much is the midline shift? All of this, even fractures at the base of skull, the midline shift brought out very, very nicely. Now, the other area where there is huge potential for use of AI is that radiologists normally tend to read scans as they are done. So the scan that's done in the morning is read first, the one in the afternoon is read later, even if a radiologist is reading all of them in the evening. Now there are triaging tools which pick up a critical abnormality, and that case will rise to the top of the list for the radiologist to read quickly. Also for the technician, it'll warn the technician, hey, this is pneumothorax, kindly look at it, send it to the intensivist, let the radiologist see it. This is a CT with a fracture, or this is CT with a hemorrhage, and that'll bring it to the top of the list, so that it's not that a scan done on Friday with hemorrhage is read on Friday evening, or worse still, on Saturday. Now, the mismatches, and this is something we are very, very proud of. This is something which has been developed in caring, and this is now being used by AI developers in Harvard. It's being used at Thomas Jefferson. It's being used at Emory. It's being used in Brazil and many other parts of the world. This is a live dashboard which monitors AI performance versus radiologists, marking out the mismatches. So the yellow are the mismatches, and looking at the mismatches, you can actually click on this and a chest x-ray pops up, and then a referee, a third radiologist, can actually look at it and say who was right and who was wrong. A second radiologist actually acts as an arbitrator. Now, our experience of using AI-based QA oral, this was a presentation we did at RSNA 2019. The impact of AI was that 12 wrong reports were avoided by AI, 708 normal cases reread by AI, 46 labeled as abnormal, 46 cases reread by arbitrator, and 12 cases with truly missed findings. Automated lung nodule detection and characterization. Again, this is something we presented at the RSNA, and this is, again, the results were dramatic, that not only was it able to recognize the nodules and number them and count them, give their sizes and all of that, it was also able to predict whether it's benign or malignant. And if we looked at the accuracy, the radiologist's accuracy for benign malignant was about 78%. The AI accuracy, even in the early years, was about 85%. So there's something there. Then improving bone age estimation. Again, this is a paper we presented at the RSNA, where automatically you can do bone age estimation. Then automatic classification of chest x-rays as normal, abnormal, using a high sensitivity deep learning algorithm presented by us in ECR. And here again, it can identify the normals, and the radiologist may not need to look at them once your dependence, once you know that your AI algorithm is very, very good. And again, this is currently deployed at our place. This is again something from Stanford, where it says AI will be the physician's assistant for reading TB x-rays. And again, this is something which is in use. Then diagnosis of Alzheimer's disorders using a resting state functional MRI at the individual level. And further, what I can say, AI will lead to integrated diagnostics as more and more data comes, as more and more people are there, and more investigations. You have radiology, you have pathology, you have genomics, you have clinical data, you have biochemistry, so many things. AI will help in combining pathology, radiology, and genomics. Mutual interdependence is there, but there are limited touch points. And we have to move beyond the traditional radiological pathological correlation, and AI may be able to be the tool. There will be an integrated diagnostic workstation. Some of them are experimentally there even now. Images with radiologists and pathologists sitting side by side will be viewed together. They will instantly resolve any discordances and provide a reconciled report on all concordant cases. This will improve quality, reduce risk, and we see an instant potential in breast cancer. And if we say digital integration has already started, and there are some examples of it around the world, the future of radiogenomics is that genomics data, detailed imaging data, be it PET, CT, MRI, clinical follow-up data, will all be collated, and by machine learning systems, and we will have this genetic risk, exome sequences, acquired risk, this detailed history taking, other history of smoking, exposure to carcinogens, viral infections, exposure to radiation. We'll be able to tell the current status. Do I have cancer right now? This is some which patients ask, people ask. That will be done by a whole body MRI. And then, what is my risk of getting cancer or getting heart disease or getting Alzheimer's? That will be done by genomics. And we have this unique ability to do whole genome, whole exome sequencing, and be able to bring the two together in the future. The diagnostics department of the future will be an overarching department where radiology, biochemistry, pathology, genetics will all be together. And we will have probably a new diagnostician called the clinical information specialist. And he will bring everything together, give it in a chewed manner to the clinician. So the Integrated Diagnostics Institute will have clinical diagnostics, imaging, pathology, genomics. There'll be disease-based approach, oncology, neuro, cardio, pediatrics, etc. There will be population health and integrated screening, diagnostic optimization, innovation, and of course, you'll need computational sciences and AI. And this is actually the diagnostics of the future. And this is our small step towards it. This is our new diagnostics lab that is going to open in about 2 months. It's about 30,000 square feet, where at -1, there will be 3 MRIs and a spectral CT. At 1 will be molecular imaging with a PET CT, gamma camera. 2 will be ultrasounds, X-rays, CBCT, DEXA, what have you, everything in radiology. 3 will be AI, genomics, routine pathology, biochemistry, all of that. And 4 will be teaching and training spaces and learning. And so, ladies and gentlemen, thank you very much for giving me this opportunity. And I showcase you Carpal, which is the caring analytics platform, which is installed in different parts of the world. And we are building really the world's first end-to-end validation and deployment platform for medical imaging, AI. And, you know, if you ask me, AI will not substitute doctors anytime very soon. But because there is the conundrum of ground truth, who's going to say what is true and what is not? Millions of scans, proof of ground truth. Is CT the ground truth for a chest X-ray, or histopath for lung nodules? And then what is normal? Are these situations normal? Chest tube in an ICU, unfolding of aorta, aortic calcification, vertebral osteophytes. What takes a second for a seasoned radiologist to dismiss as unremarkable may be very difficult for a computer till it's taught very, very well. And then the clinical context. AI currently analyzes only images. It's impossible to meaningfully incorporate clinical details at the present point of time, even with all the advancement that has happened. There is no mention of clinical history or vitals in an algorithm. And we know, as doctors, as radiologists, as pathologists, we diagnose patients, not images. And so that's where I feel the doctors are not going away any soon. But AI will be doing some machine-like human functions in the next 5 to 10 years. It'll auto-measure everything. It'll flag studies with critical findings. It'll identify normal scans, be it chest X-ray, HCT, mammo, and it will auto-pull relevant data from EHR systems. And future for young doctors, AI will work as radiologist assistant, improving productivity and quality, will replace radiologists for certain areas of reporting, will help clinicians read scan and lead to turf erosion. That's going to happen. It's inevitable. Will help in reading scans in underdeveloped parts of the world with limited number of radiologists. will impact teleradiology providers and armchair radiologists who never meet the patient or the physician, as there is no human face to the radiology report. So we need to be clinical radiologists, clinical pathologists, become a part and parcel of the team which is treating. Otherwise, if we are just a written report, it's very easy for AI to replace us. But there are questions regarding liability of AI-generated reports. Who is liable? Is it the supervising radiologist? Is it the physician? Is it the AI company which developed the algorithm? Is it the hospital? Is it the insurance company? These are questions which still need answers in the future. But one thing is certain, it'll definitely improve turnaround times and reduce healthcare costs. And I conclude by saying, let's change before we have to. This is something that was said by Jack Welch, the legendary chairman of GE Healthcare. And he also said, control your destiny or someone else will. So we as doctors, as radiologists, as diagnosticians, as pathologists, as diagnostic specialists need to control our destiny and not run away from the change, but adapt to it, adopt it, and become better for it. One thing is definitely there, that radiologists with AI will definitely replace radiologists without AI. These are some of our collaborators, MIT, Stanford, our own IIT, JNU, Max Planck Institute, and of course the large companies and small little startups in India and around the world. Thank you so much for giving me this opportunity. And if I've overshot my time, it's only because of my passion for this field. Thank you so much.
Thank you, Dr. Mahajan. Most fascinating and thought-provoking talk, and very passionate two speakers that we had in this session. And all the listeners, I can see 145 logged in. I'm sure they were glued. I did not see any change in the participants over there. There's a question in the box there that you did not touch the ultrasound, and you did not touch clinical microbiology also. I'm glad.
Yes, yes.
So I have actually tried to show most of what we have done. We've done very limited work in ultrasound.
You have dissected the whole body without dissecting it. So what more would you do? तो कहते हैं रहम करो भाई. Wonderful, sir. Wonderful. Very thought-provoking.
Thank you, sir.
Absolutely wow. Absolutely wow.
About the ultrasound that has been asked.
Ultrasound, yes, I will allude to that. Ultrasound already in the high-end machines that we are getting, AI is being used to auto-measure. AI is able to recognize normal structures like femur or do automatic measurement of a fetal skull and things like that, and do volumetry. All of these things are already there. And as it evolves more and more, even there, it'll be able to help the radiologist. And in countries like the US, where technicians do ultrasound and the radiologist looks at those pictures and just reads the scan, I'm sure there in the years to come, even that will be, AI will be able to do a great job, because there's a set pattern to the way you acquire the images, just like CT and MRI. So already work is, there is use of AI in ultrasound. It's inbuilt in machines, and the future is pretty bright.
May I make a comment?
Please, Seema.
Thank you.
It has been so exciting listening to you that I wish I was at the beginning of my career rather than so old. I would like to start all over again.
I think all of us are still, young and at the beginning of our careers, because this is a new career. As they said, change before you have to. And I think we'll all change. We need to change. If we've reached this stage in life, it's because we adapted and changed as circumstances changed. from the 1980s and 90s when we started to now is a huge change. And this, I think, our generation has learned to leapfrog. And I'm sure the younger ones who are born into this kind of a milieu and this environment, for them, adoption will be much easier. But, you know, we've adopted so many things, you know, from you know, one colony having two people with phones in their house and one ambassador car, which was there in the whole colony. We've come a long way. So I think we are the most adaptable generation. At least of my age.
We have burnt at both ends. We have burnt at both ends.
Or learnt at both ends, sir.
I wish to hand over the mic to my co-chair, Dr. Jayalakshmi, to wind up. And I thank Dr. Seema Bhargav for giving us this opportunity and Dr. Alok Ahuja for giving us this opportunity. Over to Dr. Jayalakshmi.
Thank you very much, sir. It was an absolute pleasure, Mahajan sir, listening to you. It's almost like, you know, looking into the future. So you say it's today and we have to learn more and then upgrade ourselves. Thank you so very much for that wonderful talk. Thank you very much.
It's an honor.
Thank you, Harsh. My special thanks for sparing this time for you.
No. It's an absolute honor.
You've been awesome and you've been a real superstar today.
Thank you so much. You're too kind.
Thank you, sir.